Good morning to all. Today we are going to cover our third topic of epidemiology. The first topic was tools of epidemiology. The second topic was descriptive epidemiology that we have covered. And the last portion of the descriptive epidemiology was formulating a hypothesis. So that part I will be discussing along with analytical epidemiology to get a continuation of that topic. So still now what we have done is describing a disease. So in descriptive epidemiology, we will be getting a clue to the etiology of the disease. To confirm that clue or the evidence what we got from descriptive epidemiology, we have to conduct a specific test or specific study, that is your analytical epidemiology. And for some studies, we can do experimental epidemiology also, but for some studies, it is not ideal or it is not possible to conduct a experimental research or experimental study. So we will be stopping with analytical studies, that is case control and cohort studies. So we will see some slides. So these are the contents which we are going to discuss this particular topic: a history, introduction. Then in introduction, we'll tell about hypothesis, what is a hypothesis and how to write a hypothesis, and the steps in case control studies. And the steps are selection of cases, selection of controls, matching, measurement of exposure, analysis and interpretation. And problems in case control studies, then advantages and disadvantages, nested case control studies, summary and conclusion. So coming to hypothesis, a supposition arrived at from observation or by reflection. As we told earlier, from descriptive epidemiology, we are going to get something called as hypothesis. So now we want to test that particular hypothesis. Before testing the hypothesis, we are supposed to write it in a format, what we are going to do. Then comes your null hypothesis and alternate hypothesis. That will cover it in another topic, or it's beyond the scope of this particular area. So I will give an example how to write a hypothesis. This can be an ideal hypothesis. Smoking 40 BDs per day will result in leukoplakia among 4% of BD smokers after 10 years. So this is what is going to be your hypothesis. So the hypothesis should be like it should mention the population to be studied. So the population is a smoking population that we have mentioned already. Then the cause being considered, is 40 BDs or 40 to 50 BDs, whatever it is, per day, consuming 40 to 50 BDs per day. It is the cause. And the expected effect or disease. The expected effect or disease is going to be leukoplakia, that is mentioned. And dose response relationship that we have mentioned, that's 40 BDs per day, and getting a response of 4% population getting a particular disease. Here it's leukoplakia. Then comes the time response relationship. The time response relationship is going to be after 10 years. For some disease can be 1 month, for some disease can be 2 years, 3 years, for some disease can be 10 years and more. So this is a comprehensive hypothesis writing. So once you write your hypothesis, you want to test this. For that, we have to go through the steps of particular case control studies. So the three distinct features of a case control study is both exposure and outcome have occurred before the start of the study. The study proceeds backwards from effect to cause. It will go backwards from effect to cause because the effect has already occurred. So we are going backwards and collecting the data from the particular patient. And it uses a control or comparison group to support or refute an inference. Here we are using a control group. The control group, the ideal property of a control group should be the control should be free from the disease, and we are taking history from the particular control group also, so that we will get a contingency table. We can do some mathematical calculation to refute your inference. So coming to the history of case control studies, 1940s, Alton Ochsner, a surgeon in New Orleans, he conducted an operation for lung cancer, showed a history of cigarette smoking. All the patients who he has treated has a history of cigarette smoking. In 1940s, Sir Norman Green, is an ophthalmologist in Australia, observed cataract in children who were in utero during time of rubella outbreak. So the two terminologies here we commonly used are exposure and outcome. The factors with which individuals come into contact is called exposures, and all possible results that occur because of exposure to a causal factor. This is the outcome. Outcome can be death, it can be a disease, it can be a cure, and it can be a number of things. The outcome depends on your exposure. So to just give an introduction, what we told already, just summarize. It's the first approach to test a causal hypothesis, used for serious conditions, helpful in cases of chronic diseases. The hallmark of case control study is that it begins with the people with disease and compare them to people without the disease that we have already discussed. So a pictorial representation can be like this. The top portion shows the case control studies. When we come to the right hand side of the slide, you can see the people who are having the cancer and the comparison group, which are non-cancerous patients. So then taking the histories, we'll go backward. This is also called as a retrospective study because of the nature of collecting data retrospectively. So we'll have a group, two exposure groups or two exposure data. Then we will compare that to exposure data to draw a conclusion. So the bottom part of the slide shows your cohort studies. Here it is starting from left to right. The group of interest, there will be smokers, there are exposed people, and those who are non-exposed people, non-smokers. Then we will go and follow them over a time, and we'll collect the data from them, and then we'll compare the result for your inference. So if you use a proper case and a proper control and the exposure is collected, then we get a table something like this. This is called as contingency table. This is a 2 into 2 contingency table. It can be 3 into 3, 3 into 2, 3 into 4, any number. Steps of case control study. The first step is selection of case. Selection of case. Then the next step is selection of controls, and the important steps is matching. Then comes the measurement of exposure, analysis and interpretation. Selection of cases, selection on the basis of diagnostic criteria, eligibility criteria, and specified period of time or advanced cases. And come to the selection of controls, and here selection of cases, selection on the basis of diagnostic and eligibility criteria. Once the diagnosis is made or the diagnostic criteria is made, we are not supposed to change that particular diagnostic criteria when we are selecting a case. For example, if you are checking for a cancer, if histologically we have to define which type of cancer you are going to take as a case, whether it is a moderately differentiated or well differentiated. So that is what is a diagnostic criteria or the definition of your diagnosis. It's not the theoretical diagnosis definition what you're writing in your theory books. It should have a practical content in that. That's what diagnostic criteria is. Then comes the eligibility criteria. There's a specific period that patients who have got disease in particular year or particular time period or particular age, particular gender, all that things comes under eligibility criteria. Once you made your diagnostic and eligibility criteria, you are not supposed to change it. And sources of cases, general population. Now from where you are going to get your cases? So that's the next thing, that is from general population and hospital. General population, it can be from a specified geographic area or through a survey you can select the cases. And from hospitals, it is a little more easy to get the cases because they will be admitted or they will be coming to hospital for the references. So hospital cases will be easy to identify and easy to get the patient from there. It can be from a single hospital or from multiple hospitals. Then comes the selection of controls. Control must be free from the disease. They must be as similar to cases except for the absence of the disease under study. So clinical form of disease is difficult to identify. The control must be free from the disease. That's only one criteria which should be fulfilled by the controls. It should be free from this particular disease which we are going to study. They must be similar to cases as possible. As much as possible, it should be similar to cases. So an ideal control for a case will be his brother or his twin. So the subclinical form of disease is difficult. Some cases or some diseases they've been in subclinical stage. So that time, if we are taking them as a control, it can confound your results, or it can make some error or bias to your results. And selection of controls, again, from hospitals, we are easy to get controls. The patient with some specific disease which is out of the study, which can be taken. Can be taken from a different department, like if you're doing a study on oncology, you can take the patients or the controls from the patients of gynec department, cardio department, or GI departments. Then non-hospitalized control you can get from general population, neighborhood population, best friend, and siblings. These bottom two are little more ideal for selection of a control, your neighbor or your sibling. And coming to number of cases to number of controls, maximum you can have 4 controls for a particular one case, and minimum it should be 1:1. Otherwise, it is going to confound your results. Then comes the main step that is called as matching. Matching is the process, by definition, matching is the process of selecting the control so that they are similar to cases with regard to certain pertinent variable in characteristics, like age, race, gender, occupation, and socioeconomic status, which are known to influence the outcome of disease, and which, if not adequately matched for comparability, may distort or confound your result. So as I told, if we select 2 groups, cases and controls, we are supposed to match them for all other factors as far as possible. And the only difference they should be is like the absence of the disease. Then come to one of the important area, what is confounding a factor. By definition, it's a tricky definition, it's a little difficult definition. A confounding factor is defined as one which is associated both with exposure and disease and is distributed unequally in study and control groups. More specifically, a confounding factor is one that, although associated with exposure under investigation, is itself independently of any such association a risk factor for the disease. By definition, it will be a little difficult to understand, so I'll just explain an example. So suppose we are studying esophageal cancer, and the exposure what we are looking for is alcohol consumption. Smoking can be a confounding factor, or smoking will be a confounding factor, because alcohol and smoking is related. Those who consume alcohol, they will be consuming, or they will be smokers. So always when you've seen watching films and all, you must have been seen those who are drinking. The glass will be there on the left hand, and one cigarette will be there on the right hand. So that both of them are very interrelated. And this particular smoking, which is not the interest in our particular study, our interest in this particular study is alcohol, but smoking here is itself a independent risk factor for esophageal cancer. So these kind of situations, they may result in error in the particular study. So that is what is a confounding factor, and here smoking is a confounding factor. Coming to another example, if you're checking for oral cancer and tobacco chewing, age is going to be a confounding factor. Age is almost everywhere, it's a confounding factor for any such diseases. So here oral cancer and tobacco chewing are the exposure and outcome of our interest. So those who are chewing tobacco, when age increases, the age itself is a risk factor for increasing cancer, and the age itself has a relation with tobacco chewing. I'll explain. Like when the patient is cumulative chewing, or cumulative chewing can happen when increase in age, because when age increases, the number of chewing cycles or number of episodes of chewing also increases. So that itself is a risk factor for oral cancer, and this tobacco chewing will increase with this age also. So here the main thing what we can do is to reduce the confounding, we can do age matching. So this is the importance of matching here. So if you match the age according to a particular age group into 2 or 3 or 4 different stratas, then we can reduce the confounding by doing different statistical tests for that particular stratas. So that is what is called as confounding variable, and how to do that matching. If you do a group matching, as I told earlier, you can group them into strata according to age, occupation, social class. Then pair matching you can do, 1:1 pair matching you can do, and sometimes you can do unmatched controls also. Unmatched controls, there's one more technique to reduce the confounding or cut the confounding factor. That is what is called as statistical methods. Usually it is done by regressions, that is logistic regressions. So that can be done. Then again, it's out of this out of the scope of this particular presentation. These are statistical techniques which can reduce, that is, as I told, logistic regression. Then there's something called as linear regression. All these regressions can be done. And measurement of exposure, how we are going to, now we have got a case, we have got a control, and we have done the matching. Now we are going to measure the exposure, or we are going to take the history backwards or retrospectively. So the techniques which we use are interviews and questionnaires. Then for some diseases, when you are checking for a cholesterol or any other parameters which is related to your blood, that we can get laboratory measurements and laboratory records. Then if you are checking for height, weight, all that kind of things, you can get the physical measurement. So it depends on the study which you are going to check, and the measurement you are going to, the exposure you are going to measure. It will be different for different studies. Then comes to the analysis and interpretation. It's a little difficult portion. So now if you do a case control study, you are going to get a contingency table, and you are going to measure 3 main things in case control study. One is exposure rate. The other one is the estimation of your risk, that is relative risk and odds ratio. Relative risk, it's difficult to get in a case control study, but for as an alternate, you can take odds ratio. So this is what is called a contingency table. When you see vertically the cases, there are 35 cases, and when you come to control, there are 82 controls, or almost 1:2 proportion. We are 1:2 we are getting here as case and control. When we taking the history, out of these 35 cases, 33 are exposed to smoking and 2 are not exposed, those who got the disease. And coming to control, the smokers are 55 and 27 are non-smokers. So now how you are going to calculate the exposure rate? If you do a vertically a calculation, A by A plus C, you are going to get your exposure rate of your cases. 94.2 is the exposure rate. This 94.2 is the percentage of people, or 94.2% of people, those who got the disease were smokers. So it's a high percentage. It will be a significant number. And in controls, that is 67%. Out of the cases, out of the controls, and 67% of them were smokers. But fortunately or unfortunately, they have not got the disease. That is, this 55%, 55 number of the controls which you are seeing on the right side is the luckiest people, and these luckiest people are the most dangerous ones, because they will do the propaganda that smoking is not going to cause any harm to you, but it's sheer luck which they got, because they are not got the disease. They may get in another situation if you are taking them as a prospective in studies. If you include in prospective studies, another 3 years, 5 years, they can get the disease, or they will be in a subclinical form of the disease that we can't tell now. So these are the things, and the unfortunate people in these groups are C. They're non-smokers, but they got the disease. They can be a secondary smokers. It can be some due to some other reasons. We have studied that there are some post reasons for developing any disease, and there are some social and other post reasons for that. So these are the particular steps. Then comes your relative risk or risk ratio. It's calculated by dividing the risk of an outcome in one group by the risk of the outcome in another group. This is not always possible or not always correct in the case of case control studies. So this is how we will measure the relative risk, that is incidence among exposed by incidence among non-exposed. You divide your exposure rates of cases and controls, you are going to get estimation of the risk. Then comes the odds ratio. This is the cross product ratio. It is a measure of the strength of the association between risk factor and outcome. That is a cross product ratio. If you do A into D and D by B into C, you are going to get a value, that is here it is 8. If you get the value of 8, this is this we can represent as the risk. Like it is 8 times more prone to develop a cancer for those who smoke when compared to non-smokers. So now the result of the study, this is what we can call as a result of your study. We can mathematically now tell or confirm that, yeah, this is 8% or 8 times more chances of developing a cancer for a particular group of people, that is here smokers. So a odds ratio to be determined, it should be a rare disease. Not always it's like that. We can calculate for almost for all diseases. And cases represent those with the disease, and control represent those without the disease. So odds ratio is calculated by your cross product ratio, AAD into BC. And the problems in case control studies are limitation of human recall, that is called as recall bias, and biases will be dealing with your next portion, cohort studies. So limitation of human recall. Sometimes there will be a recall bias happening in this particular cases, and there will be a confounding bias that we have already discussed. What is selection bias? When we make an error in selection of cases and selection of controls, there can be a selection bias. And limitation of human recall. Here it can be recalled as recall bias or memory bias. When we are taking a history backwards, the patient may forget the history of smoking or how many cigarettes he smoked back to 15 years. That would be difficult to recall. Then coming to advantages of the case control studies, relatively easy to carry out. It's rapid and inexpensive. We are having the patients, we are taking the patients initially and we are going backward. Just you need to have some time, that's all. And requires relatively few subjects and suitable to investigate rare disease about which little is known. Because the prevalence is less, it's very difficult to get a lot of people to get into a cohort study. Case control study, we have just to got that particular group of patients and go backwards. And no risk to subjects is very important, because the ethical issues are very less, because they have already exposed and already got the disease. So we are just taking a history. Unless in a cohort study, we know that this is going to happen, and we are sometimes intentionally exposing that particular patients. Allow study of different etiological factors. If you have an aim and objective, if you have a secondary objectives, we can just check that also by asking the history. Nothing we are going to lose in that particular case. And no attrition problem. This is compared to a cohort study. In cohort studies, there is a chance of loss of follow-up. Patient can discontinue the studies in cohort studies. That problem is not going to happen here. That will be detailed in your next portion. Then, as I told, ethical problems is minimal. And coming to the disadvantage, problems of bias as results are dependent on memory or past records, which may be misleading. That we have already told in the limitation of the case control study. And selection of appropriate control group is difficult. Sometimes there will be difficulty in selecting a control group, particularly if the disease is very much prevalent in the community. So it's very difficult to get a particular control, because subclinical cases will be more. And we cannot measure incidence, only measure relative risk. Measurement of incidence is not possible in your case control studies. It is possible in your cohort studies, and does not distinguish between cause and associated factors. Representation of cases and control is a problem that I told earlier, and not practical for rare disease, the rare exposures. So these are the disadvantages we are having with the case control and cohort study. So by this, we will be ending our particular session. I hope you are clear with this particular area. Then the advantages and disadvantages will be clear more clear when we deal with the cohort studies. Thank you.